Good afternoon, everyone. Thank you for joining us today. This is our fifth virtual program ever since the lockdown began. My name is Bunty Chand, and I'm the Chief Executive Officer at Asia Society India Center. Asia Society's programs across our 14 centers are now virtual and global. In May, Asia Society conducted 70 programs across the world. So if you have a dull or spare moment, you know what you need to do. Get on the Asia Society YouTube channel. So this is Asia Society India's fourth program in Overcoming the Pandemic series, where we have tried to address some of the most pressing concerns India has faced in the past few months. We have previously hosted discussions on food security, importance of data, and community healthcare. And all these videos are to be found on Asia Society's YouTube and Facebook accounts. In today's program, we deliberate about possibilities and options that lie before India as the country plans to ease the nationwide lockdown. In Australia, a group of leading medical experts devised the roadmap to recovery. It's a report based on evidence to offer solutions on how the country can deal with the pandemic and the aftermath of the pandemic. And we have with us Dr. Shitij Kapur, who's one of the co-chairs, who will shed some light on the report and share his views on some of the solutions that could work for India. Our India-based speakers, Mr. Ashok Alexander and Dr. Shahid Jameel, both with vast experience in HIV, will speak on the impact of the virus and ideas and suggestions on near to midterm recovery. I would once again like to welcome our panelists today, Ashok Alexander, who's founder director of the Antara Foundation and former India country director of the Bill and Melinda Gates Foundation, Dr. Shahid Jameel, a virologist and CEO of DBT Wellcome Trust Alliance, and just a minute, I've lost where I am. And Dr. Shitij Kapur, who's Dean Faculty of Medicine, Dentistry and Health Sciences, and Assistant Vice-Chancellor of Health at the University of Melbourne. And the discussion today is moderated by Divya Rajagopal, who's Senior Assistant Editor at the Economic Times. And just a bit of housekeeping before we proceed. All of those who are joining us on Zoom, please leave your questions in the Q&A section. And our audience on Facebook, please drop the questions in the comment section. And now I'm going to invite Divya to start the discussion. Divya.
Thank you so much, Bunty. We are entering a new way of life, hopefully. And I think as the lockdown ends and the world and India limps back to a new normal, we have three experts here who perhaps will give us some idea on what this new world order is going to look like. Are we going to go back to the older ways of living, or is there some fundamental changes that we need to sort of make to our lives and to the society as we step into post-pandemic world? So I'll start with you, Dr. Shahid Jameel. This is specifically to do with India. We are opening up at a time when our number of infections is growing. If you see most of the countries across the world, they opened up when they saw some sort of a curve that was some sort of flattening that was happening to the number of infections. But we are opening up when the numbers are rising. In the last 65 days, what, according to you, have been the learnings from the COVID progression, and what is it that we need to do going forward?
Well, Divya, let's look at the facts and look at some numbers. When the lockdown started on 25th of March, India had 657 confirmed cases and 12 deaths. On the last day of the lockdown, which was May 31st, we had 198,609 cases and 93,349 active cases and 5,408 deaths. Today, we have 257,000 plus cases and 7,207 deaths. In the last 24 hours, we have added 10,864 new cases and 261 deaths in India. I'm not saying this to scare people, but these are the facts. The negatives from the lockdown are that the cases increased 300 times, the deaths increased 450 times, the daily cases increased from 121 per day to roughly 8,700 to 9,000 per day on an average. This is a 72 times increase. The testing has increased, but the testing is still low at about 3,300 tests per million population. The other negative, and a very significant negative, is that internal migration because of an unplanned lockdown has taken the infection to villages and small towns from the cities. But all is not negative. There are positives. The positives are that the recovery rate has gone from about 9% to about 50% in the lockdown period. The case doubling rate has increased from about 5.5 days to 16 days now. The testing capacity has increased to about 1 lakh tests per day. Without any intervention, India was predicted to have about 53 lakh cases by 20th of May. What we actually had was 1.12 lakh cases, confirmed cases. The mortality rate in India has remained low compared to a global mortality rate. Now, what do we look for ahead as we move in the post-lockdown period, in the unlock period? Most epidemiologists believe that a peak will happen sometime around mid-July. If on an average we are adding about 10,000 confirmed cases a day, that's about 3.5 lakh new cases over the next 35 days. So we are looking at a total of roughly 6 lakh cases at peak time. But then the peak is not going to just go down sharply. The peak is going to go down slowly. It will be a bell-shaped curve. And if we have another maybe 2.5 lakhs on the other side of the curve, on the downward flow, we are looking at about 9 lakh cases by the end of September. But this number is likely to be much higher because we are assuming that we will have only 10,000 cases coming in per day. The outbreak is growing at a rate of about 4.3% daily. So this number is also going to go up. The next point is, how many cases do we really have? And I'm not going into whether there is underreporting or not. I'm simply giving you a new way of calculating it. Death is hard to miss. Somebody who dies, dies, and we are assuming that that person is recorded as dying of COVID. If we take 7,200 deaths, sero surveys globally have shown that the population infection rate is much higher than the confirmed case rate, and therefore the population mortality goes down. So population mortality has been estimated at somewhere in the region of about 0.2% to 0.7%. And if we simply did a multiplication of the 7,200 cases today by a factor of anywhere from about 140 to 500, depending upon whether you believe 0.2% or 0.7%, we are looking at roughly in the range of about 22 lakh to 75 lakh cases as of today, as opposed to the 2.5 lakhs that have been confirmed. So we have to keep these numbers in mind. Finally, what have we learned? What we have learned is that there is no substitute for testing. If you cannot measure, you cannot control. So therefore, testing has to be at scale and testing has to be smart. The second point is we need to gather high quality data and make this data transparent. India's data is very granular. It's very hard to find, and it's even harder to analyze and interpret. The third point is, please follow expert advice. There are uh, we see in the media that Ministry of Health has ignored even the advice of its own empowered committee in pushing a hasty lockdown. I would hope that we at least follow advice in the unlock period. Treat this as a public health problem, not as a law and order problem. And therefore, trust is the key. And Kerala has shown us that trust plays a very big factor. Science and industry have come together very well to tackle the outbreak at multiple levels, both globally and within India. If you look at globally, there are about 40,000 sequences in the public databases, about 130 vaccines in various stages of development, about 10 in clinical trials, repurposed drug trials. Even within India, we have about 500 sequences in the database, and work is going on to put about 50,000 sequences from India in the database. So that will be phenomenal. About 30 vaccine projects are ongoing in India. Vaccine industry, you know, has geared up already to manufacture some of the leading candidates that are coming out of in the world. There are 21 off-patent drugs that CSIR labs have developed processes for, and they are being transferred to industry. India went from a country which had zero capacity to make PPEs. Today, we are the second largest producer of PPEs in the world in a course of about 3 months. So we have tremendous capacity. It's just that that capacity needs to be utilized properly and sensibly. I'll stop there.
Right. Thank you so much. I think you've summed up really nicely. There have been gains, there have been mistakes, but of course there is so much more to learn as we go on. We'll come back to the point about testing and what India could do from here on. But now I want to come to you, Dr. Shitij. How did Australia go about its unlocking strategy? Is there some learnings for India from Australia? I think, Dr. Shitij, your audio is muted. I think you're still on mute. Dr. Shitij, can you hear me? Okay, we will come back to you, we'll come to you, Dr. Shahid, once again on the whole concept of testing, which you were speaking about. Testing has become a big controversial issue. There is one side, one field of experts, and I'm not talking about government officials, but experts who say that testing should be for those who need it. Testing should be targeted, and testing should be for the sake of finding cases and not for the sake of just adding on to numbers. What's your view on that?
No, I agree with it. But the fact is that as we have increased testing, we have found more and more cases. Mm-hmm. So it has not reached an equilibrium, which tells me that there are many more cases out there. And unless you find them, how are you going to know that? How are you going to find their contacts? And this is part of the whole strategy. The other thing which Government of India is now starting to do is to plan serological surveys to really get an estimate of what % of the population actually got infected. Thankfully, our mortality rate is lower than other countries. So I think we need to properly strategize it and really test the right populations. And some of that is happening. I'm not saying it's not happening. So for example, are we testing all pneumonia cases irrespective? Are we testing all respiratory illnesses irrespective of, whether they have other COVID symptoms or not? And there is need to scale up. Unless you do that, it will be very difficult to find where are the hotspots, where you want to control. In the unlock, we have come out of a nationwide lockdown. So now the strategy has to be to go state-wise and even state-wise to go district-wise. and even within districts to see if there are particular areas within a city, for example, that are hotspots. So unless you test, how would you know?
Sure.
Yeah.
Fair enough. Dr. Shitij, I hope you're back now. I think
I am here. Can you hear me?
Perfect. Yes, perfectly.
Okay,
perfectly well. So I hope you heard my question first.
I did indeed. So look, it's hard for me to say what about Australia applies to India, but I can tell you what happened here,
Sure.
and then we can talk about what lessons there might be to learn. So very quickly, to put it in perspective, in the middle of March, Australia had way more cases than India did. We were actually accumulating cases somewhere in the range of about 400 to 500 a day. But today we had only 3 new cases. So it has dramatically changed in that time, and Australia has gone down at the time when India has gone up. Now, one should know one thing about the Australian cases, that 90% of our cases were imported. So the reason it became easy to control, even though we were having 400 to 500 cases a day, most of them were actually people flying in and their first degree contacts. So it was easier transmission to control because it never really did take hold in the wider community. It was rather localized to those people. But nonetheless, from those numbers now, as I said, we were down to almost 3 a day. So it is, and we have 6 states and 2 territories. And at the moment, 6 of those 8 have not had a case for a week. So they're actually closer to what might be a definition of local elimination. How did that come about? Perhaps the single biggest element was extensive testing. And I think Shahid has just spoken about that. Though I have to say that the rate of that testing was rather remarkable at times. So we were at peak doing close to 50,000 tests a day in a country that is only 25 million people. So if you scale it to the Indian version of it, India would have to do something like 15 lakh tests a day to reach the same level of testing. Now, I'm not saying that level of testing is necessary. Perhaps a smarter algorithm could be developed, but nonetheless, that is what happened here. But there were a few other elements that were very important. We went down into lockdown at that peak when I was saying 400 to 500 cases a day. And we did not come out of lockdown till the number had gone down to about 40 a day. And even though the number is down to 3 a day, and I am saying that 6 of the states are near elimination, life here is not back to normal. I cannot have a big dinner party at my place even today, and the universities are not open. So you can see we are still under rather prohibitive social distancing, even though it's much looser than before, even though we practically don't have many cases. So the second point is, not only do you need to do testing, but people have to adhere to the rules of social distancing. And very critical in that was people's trust in politics, or not politicians. This is not usual for Australia. So don't for a moment imagine that Australians love their government and do whatever Scott Morrison says. No, it is the way the government dealt with people this time. It earned the trust of people largely through transparency. Data were always public. Uncertainty was always public. Every time that Scott Morrison, our Prime Minister, used to come and speak, the Chief Medical Officer would be by his side. Scott Morrison would open the mic, hand it over to the Chief Medical Officer, who would actually detail what was going to happen, and then Scott Morrison would take the questions. So it was seen as a very much expert response rather than a politically driven response. So I would say those are the elements: testing, public engagement, and trust earned through transparency. How that applies in India, I'll leave that for you to debate with us later, but I think I'll end there.
Sure. But when, again, sticking to testing, because it's become such a hugely controversial part across the world, I think, is how did you test? Did you sort of have a specific criteria on who will get tested? Right?
Yes.
Could you take us through that? Who were the people who were getting tested?
So it wasn't random testing, and it wasn't anyone could walk in and get a test until very recently, until our case numbers came really down. Testing wasn't open for people to decide by themselves and walk up to a testing center. Right. Testing was always determined by a public health and a clinical strategy. So special testing centers were opened up across the state, and you had to meet certain criteria. The criteria were different depending upon your demographics. They were also different depending upon where you had traveled and who you had been exposed to. So even though I said we had 50,000 tests per day for a small nation, they were still not a free-for-all. It was a algorithm-defined strategy that made sense, and it kept changing through the different stages of the pandemic. So no, it can't be a free-for-all in any case.
Sure, that's what, because I think there's also a lot of confusion when the call for testing comes in mass testing, people confuse it that there will be some sort of door-to-door testing that would happen.
No.
Sure.
That wasn't the case.
Sure. Thanks for the clarification. Now, Mr. Ashok, I'll come to you. We've seen that across the world, most people who are working on COVID-19, including immunologist Anthony Fauci, have gathered their experience working with HIV. We've seen even in India, the ICMR folks who are leading the COVID strategy have the experience from HIV days. Is that some learnings that we have sort of missing out and we are not applying that for COVID?
Yeah, Divya, without meaning to duck your question, I'll come back to the HIV COVID connection that I see. But I'd like to offer some perspective on the rural epidemic that nobody speaks about, or the potential rural epidemic. And the reason I do that is because I work at the grassroots of 3 states in the north, and I travel across northern states. And the 3 points I want to make is that I seriously worry about a rural epidemic. And secondly, that it's necessary for government to start by strengthening facilities and strengthening the hands of the 3 frontline workers. Third, the community has to be central in this response, both as a watchdog and as a trigger for quick action. And if you look at all of these solutions, you can take COVID away and say this is really a solution that should apply to it's a health system strengthening. Now, let me just touch on each of these points quickly. Why do I worry about a rural epidemic? If this was a live audience, I would ask for a show of hands to say, when was the last agitated TV discussion you heard on a rural epidemic? When did you ever see even an op-ed or even an article of any sorts on a rural epidemic? When did you hear experts opine about that in India? I think I would see very few hands rise in this audience. I certainly have not seen any of the above. And yet what I see when I work in the villages gives me cause for. One is, as Shahid just referred to, there is a migrant population that has returned to the villages and is coming back. Prevalence in some of these populations has been measured as quite high. Well, let's call that a one-off effect. But there are other reasons. There's, let me call it the routine migration, which is considerable, that is continuing to happen between villages to towns and back. An auxiliary nurse midwife whose job is to travel between 5 villages, and she examines patients and travels continuously. There are festivals, jatras, large assemblies which are part of rural India. There are high levels of malnutrition and very high levels of anemia amongst women. And these are severe malnutrition makes you more vulnerable to viral diseases, including COVID. And if you put all of this together, you look then at the facilities. What if there are lots of numbers of people getting sick in rural India? Where do they go? We're talking about, states where 40 to 50% of facilities at the primary health center don't have any doctors. Almost the same number of nurses are missing. 30% of facilities don't even have water. So what I'm trying to say here is that if the rural numbers start getting even a little big, you are going to have a very, very worrying situation. So I'm expressing some of my concern that we don't even seem to discuss this. And for me, it baffles me as to why. Now, down at the grassroots, what do we see? The government is taking steps. It's getting training supervisors and the frontline workers. But for people who've never worked on a live virus and an epidemic in crisis, this is very new stuff. So when we talk to people informally and through informal surveys, what do they really understand about? There's almost, there's a worrying level of lack of knowledge. So let me put this aside. I'm not trying to spread alarm, but I'm trying to spread concern and the need for concern. What does government have to do? One I just referred to. Our infrastructure is a sham. I mean, it's a shambles. You can't handle any health system with this kind of infrastructure. So this is something long overdue, and government has to pay attention to it. What I'm going to boil down to is this: it's a community-led response that is needed. What do I mean by community? I work in maternal and child health. I used to work in HIV for a long time, but I work in maternal and child health. HIV has taught us, and maternal and child health work has taught us, that if you're looking at case detection, the crux is prevention. It's finding those cases that might become COVID cases, might become high-risk pregnancies or high-risk newborns. You have to spot them in advance. And that is the challenging thing, because when you have a village of 1,200 people, there's just 5 or 6 high-risk cases. So you have to have methodologies for doing that. This can only be done in HIV, in polio, in COVID, in a rural context, if you have the community involved. By community, I mean 2 people in the Indian context. There are the 3 women, we call them the AAA, the ASHA worker, the Anganwadi worker, the ANM. And then you have the pregnant and lactating mothers, or let's say the village community. They are the ones closest to the problem, and they are the ones who will always have the knowledge. Now, community has generally been ignored or taken as a passive recipient of services that are provided by government or someone else. We found in our work that by creating something that we call a AAA platform, where the women come together, they use an app, they do village mapping, they pinpoint the houses which are at risk, get there quickly and take action. The detection of underweight children, high-risk pregnancies has doubled and tripled in just under the course of a year. So I'll end by saying that this is not a COVID solution as much as a health system strengthening solution. You can take COVID out of anything I said. Let me put some numbers in perspective. About 7,000 deaths in COVID, which is a terrible, terrible thing and a lot of anguish. But 7,000 children under 5 are dying every 2 days. And that's been going on for decades. Where is the anguish? So I'll end by, perhaps if I may make a call for compassion, because I think 3 years from now, we'll look back and say COVID was a terrible flu, but thank God there's a vaccine, and let's all go back to normal life. And meanwhile, the children will keep dying. And so I'm saying there are things that we can do to strengthen health systems, which will take care of COVID. Anything that directed only at let's get masks down, let's do more testing in rural areas, all are needed, but this is not the final, that is not the solution that we're looking for.
Absolutely.
Yeah.
Absolutely, Mr. Ashok. I think you're right. The worry right now, even for the government, is that as the migrants return home, and we are seeing the spike happening in rural India, how do we sort of tackle that? And you're right. It's a whole question of how do we strengthen the entire health system if we have any other epidemic coming through, which is not COVID. How are we going to tackle that? I completely agree with you. However, today we are still discussing a post-COVID world, and I want to put one question to you, Mr. Shahid. This is the whole question of mortality rate. Most epidemiologists now believe that we have reached a stage where we need to stop looking at the epidemic curve and we need to focus on the mortality curve. And we've seen that how do we ensure that we keep the mortality levels at the current rate or even bring them down? I think India has fairly managed to keep the mortality low, but some states still have high numbers. What needs to be done that we sort of ensure that the critical care patients are taken care of early and do not reach to the mortality stage? What needs to be done?
Well, sorry. Yeah, can you hear me?
Yes.
Yeah. Okay. So it's what we have learned through this outbreak, global outbreak, is about 80% people will have mild or asymptomatic infection. About 50, and they can be managed at home. About 15% will need to be managed in hospitals, and about 5% will need to be in ICUs. The government has built enough hospital bed capacity using private hospitals, as well as innovative methods like getting railway coaches converted into isolations and all that. But I'll come back to the point that Ashok was making, that this has to be community driven. So in his example, for example, if there is a village of 1,200 people and they can map and say that there are 5 or 6 people, maybe let's say 20 people who are at high risk, can they be isolated within the community? And this would be community driven.
Exactly.
That takes the stigma off. Today, what is happening is, health workers go in an area, put a sticker on your door saying you're COVID positive. And the kind of stigma that is attached to it, and unfortunately, this is not something we have not learned from the HIV experience, where stigma was such a big issue. So build capacity and remove the stigma, increase the trust, increase the transparency. That's one. But when people say that we should move to looking at deaths, I really don't understand what they mean, because even death rate is increasing.
Right.
Yes.
Today, India has a case fatality rate of 2.8% against a global average of 5.7%. That's very good. We don't understand why this is. Even if I take the numbers reported to be true and correct, and everyone is doing their job honestly, if I look at the scientific reasons for it, and people have speculated that maybe it is the higher numbers of other infections that give us an advantage. And it's not just us. If you look at Pakistan, if you look at Bangladesh, if you look at, Malaysia, Indonesia, Burma, this entire region, the mortality rate is low. So maybe we have better innate immunity to control the virus early on. But coming back to this, death per million, the death per million is about 5.26 right now. However, it was 3.26 or some number like that, 3.3 on 20th of May. So even between 20th of May and now, this number has increased. Doing anything in India using per million as a denominator is a problem, because India has such a large population.
Sure.
And the same people who are saying that use death per million will come back and tell you that don't gauge tests as tests per million population. So I don't understand this duplicity. I really don't think we should be going with this per million figure at all in the country. Look at absolute numbers, and they are high, and they are going to be higher. Statistics don't matter at individual levels. If I get an infection, if I die from that infection, for me, the mortality is 100%.
Sure.
So, let's not get into those kinds of arguments.
Sure. No, but of course, how do we ensure? I mean, what have we learned? And this is something which I want to come to you, Shitij. How did Australia manage its ICU cases, for example? Was there were deaths different in certain provinces, like what we're seeing in India? For example, Bombay, Delhi are seeing higher deaths.
Sure. So a few quick observations from here. So even in Australia, most of the cases are in large metropolitan areas. We managed, and we are so thankful, and we congratulate ourselves on the fact that we managed to keep it in the metropolitan areas, and it did not spread to the rural or regional areas. And I think what Ashok has said is absolutely critical, because even in advanced countries, the level of ICU support in rural and regional areas, and we have vast rural areas, would have been a huge problem. Secondly, coming to the total number of ICU beds required, if 5% of your cases require ICU beds, I would submit few countries in the world can deal with it. And look, I trained in India, so I know a little bit about how our system works. I think it would be very hard if 5% of the Indian peak, caseload at peak required ICU beds, because the challenge for us in Australia wasn't just getting enough beds and ventilators in place. We managed to quadruple our capacity. So we had 2,000 ICU, tight beds in the country. We were able to increase them to 8,000. In the end, we needed only 500 of them. So we never needed them for the moment. It might change. But the bigger challenge for us was not the beds and the equipment. It was the people to run them. The level of expertise that is required to provide competent ICU care is not very easy to retrain an average nurse or an average doctor and turn them into it. So we had to curtail all other surgeries to create the capacity that the anesthesiologists would be aware. The last point I would say, and this is something you said, Shahid, and I'd like to learn a little bit more about it, is on what grounds are the epidemiologists getting the confidence that there will be a peak in July when the cases are rising and we are loosening restrictions? So I'm a little, I have read this, I've only read it in the newspaper. I've not seen a paper that reasons its way into this, but you would know more. And I'm wondering, where is that comfort coming from?
Shahid, you want to answer that?
Yeah, so again, I am not aware of all the details, but my assumption is that it's coming from the current growth rate and the measures that have been put in. In the end, all models are wrong. Okay, so
some are useful, yes.
Yeah, some are useful, but most of them are wrong. So we should not go with the exact numbers, but I think trends are important, and the trends at this point are worrying.
Ashok, you wanted to add something.
Yes, I wanted to. I might just paraphrase to what Shai just said. I would say all models can give you the answer you wanted to give. So whether there depends on what you want out of it.
Yeah.
But I was just looking at my notes. It's an important point I forgot to make in the context of the rural epidemic. There are several 100,000, if not millions, of children who've not been immunized. Both monitoring, I think, has stopped completely. So there's a pig which has entered the python, and somehow you've got to catch up with those kids. Otherwise, we're going to have yet another kind of problem. It's a pretty serious problem.
No, I think you're absolutely right. We've been so obsessed with COVID for the last 65 days that immunization, tuberculosis, I've heard that's taken a hit, and we were supposed to end TB by 2020. So, of course, all the good gains that we had made for other infectious disease seems to be sort of slipping away.
And I'm not even mentioning women in a high-risk pregnancy who, God knows what's happened because precautions may not have been taken.
Absolutely. I think we have 10 more minutes to take each question from the panelists before we open for Q&A. 1:15 we open for Q&A. So Shahid, I come back to you again. Of course, we should not, there is no reason for comfort, even though we are opening up the lockdown. The malls are opening in New Delhi as we speak today. Bombay, which has the highest number of cases and also deaths, is partly slowly opening up. What do? We don't have a vaccine yet. Some drugs work. What are the non-pharmaceutical interventions that we can perhaps look at?
Before I come to that, you mentioned malls opening. You didn't mention places of worship opening. I think places of worship today are going to be a more worrying thing than malls. People will go to places of worship to gain comfort and a false sense of security. Beyond that, all places of worship, irrespective of religion, are closed spaces. And there are spaces where population densities are high, and there are places where rituals often require you to touch face and all of that. So I would be very worried about those places. Non-pharmaceutical interventions are known to all of us. Make sure you have a mask on in public. And it doesn't have to be a surgical mask or a respirator. A simple double or triple layer cloth mask that covers your nose and mouth is sufficient. If everyone starts wearing a mask, the transmission is going to go down drastically. Studies have shown that if only one person wears a mask, if nobody wears a mask, it's high. If one person wears it, it's moderate. If both people in a conversation wear a mask, the transmission reduces drastically. So if there is one thing you can do, please wear a mask and wear it properly. The second is, of course, proper hand hygiene. If you can afford to have a sanitizer, keep a sanitizer with you. Soap and water is even better. I'm saying this with the caveat that everyone has access to these. Everyone doesn't have access to this, and that's something else that we need to understand. avoid crowded places, especially avoid hospitals unless necessary. In some of the cities now, there is home care available if you have symptoms. So those would be the non-pharma interventions.
Right. Shitij, coming to you on what does the drug discovery and vaccine landscape look like in Australia? I know that some universities are working on the BCG vaccine. There's been so much of interest on that. But
right.
Right. So can you just take us through the treatment and vaccine work?
Right. So look, treatments and vaccine are actually an international game. Each nation is making some contributions to it, but it is really heartening that, it has been an international response. If we get one, whether it is appropriately and equitably shared around the world, I think we will get tested. But certainly at this point in time, it's an international game. The thing that's happening with BCG is interesting. BCG seems, so this is the tuberculosis vaccine, seems to confer a sort of pan immunity. And that was the basis on which from Melbourne, we launched an international trial, and now there's over 10,000. It is not specific to COVID. It is done in the hope that it would reduce the chance of a serious infection in those who, if they got infected, or might even take away the infection in some. It is still a trial, and we do not have evidence to believe, however, that if you got BCG as a child, that it continues to confer immunity. So people should not, if they have had BCG, take any comfort. We should wait till the trial comes out. But that's a sort of Melbourne-sponsored trial that's being done in thousands of people now around the world at the moment. And we'll probably know results in about 3 or so months. In terms of vaccines, look, there's so many of the international vaccines going on. A particularly Australian contribution is a new technology called a molecular clamp. It's
Yes.
a vaccine making technology. Again, it's one of the 10 at the moment. Whether it gets to be the one that works, we don't know. But I think we need to be careful to be not pinning too much of a hope on a vaccine solution. Look, it would be wonderful if it came, and it would be even more wonderful if it got to the vulnerable and those who really need it first. But I wouldn't bet on any of those two things. But the third thing to keep in mind is that people are thinking of vaccine in a binary fashion, that if we have it, there'll be zero problems. That is the case with some illnesses. Of course, if measles and polio and diphtheria, you have those vaccines, might be all right. But what we know from the viral respiratory illness vaccines, they're not the kinds that you take them once and there is never a problem again for the rest of your life. Often you've got to take them yearly. Often the virus tends to drift, though there's not that much reason to believe this one will. So look, we should keep the hopes for the vaccine alive, but it shouldn't be a planning strategy until we get there. Till then, we've got to figure out how do we live with this without the vaccine.
Right, absolutely. So non-pharmaceutical interventions is till we actually have some proven.
Or some other pharmaceutical interventions, but
Sure.
When it gets there, it'll be wonderful. But I think pinning our hopes on that may be mistaken.
Sure. Ashok, a last question to you before we go on to Q&A. Rural India, this is, as you pointed out, I think we're all forgetting what's the worry that's going to be. Your views on what should be done right now so that we strengthen the health infra there?
I've laid out some views, but if someone said you have only one thing to recommend, which will start effect from Monday morning, which is strengthen the hands of the 3 women who are responsible for health delivery and prevention at the front line: the ASHA worker, the auxiliary nurse midwife, and the Anganwadi worker. I have seen and experienced that if you put any problem in the hands of 3 women in general, but in particular these 3, they will deliver amazing results, which I may add 3 men can never do. So there are reasons we don't have the time to get into it, but if government kind of got out of the way, there are things that they can do which will have effect from Monday morning, a AAA platform, an app, and so much more.
Sure. Thank you. Thank you so much. I think we have a Facebook audience. We have questions coming in our private boxes. So I'm going to quickly start on with that. First question coming to you, Shitij. What was the test used in Australia? Was it the RT-PCR test? Who bore the cost of the test? And how accurate is the RT-PCR?
Look, the RT-PCR that was used was actually developed at our university for use within Australia. Then it was sent to all the reference labs. It is an RT-PCR test. It actually has very good sensitivity and specificity. So the problems that people are hearing about testing is often more for the antibody test than it is for the RT-PCR. And often then there are some quick and dirty ways of doing RT-PCR, which isn't actually RT-PCR, the LAMP and other techniques, where the sensitivity and specificity is low. A properly done RT-PCR practically anywhere in the world is very sensitive and specific, but there are capacity constraints. It is not easy to do it by the millions. Even the United States today is not even doing 1 million tests a day. So when people talk about universal testing and they mean by that, look, we'll test everyone, I don't think it is feasible if by universal you mean everyone. Who paid for the testing in Australia? The government did. So it was a part of the public health response. Testing was free. But as I said, it wasn't for you to decide whether you wanted to take the test. The testing had to be recommended along a certain algorithm by either a healthcare practitioner or someone else who was in part of the system. So that's our experience with testing over here.
Sure. Okay. Shahid, this question is for you. What is the potential range of underreporting of COVID deaths in India? Are there some deaths that we are not capturing well? Home deaths, deaths due to comorbidities not being factored in? Is there some way that we are not calculating the excess deaths?
Very hard to say. Very, very hard to say. Most people agree that death is underreported, not because of some evil design, but many people are not even getting to hospitals, or if they are getting to hospitals, they are being recorded as a comorbidity, whether it's diabetes or kidney disease or heart disease. So I wouldn't risk putting a factor on it.
Sure. This is a question. I think it's for a common panel. You can choose who wants to take it up. I think Ashok, you can perhaps answer this. Do we see there is some sort of economic nationalism that might emerge in a post-pandemic world and India?
Can you explain that question? I didn't really understand.
Some sort of economic nationalism. Do you think countries are going to get more protectionist? The whole vocal for local that we are hearing, or make in America or make in India, countries wanting vaccines for themselves. You see that, or even states deciding to close themselves to other states. Do you see this kind of protectionism emerging?
Well, frankly, there are two experts here who could probably say more than I can, but I have seen, from what I have seen, is that there will be, there's not enough vaccine going to be manufactured to take care of the population, especially the ones who most need them, the kind of populations we've been talking about. So the worry is, vaccine for the world, the measles vaccine developed in the 30s is still not reaching populations that need it. And so, yes, there will be. There are agencies who are supposed to sort this out. We can take some comfort in this country that Serum is the biggest vaccine manufacturer in India. So the Indian government may also do something, but frankly, this is a human problem. It's not an Indian problem. It's a poor people problem. So I hope people will do the right thing.
Right. Another question. Now, this is for the, Shitij, you want to add to that?
No, I was going to say, unfortunately, of course, the West is gearing up to first take care of their local vaccine needs. That would probably be true of any country. I think it would be politically very difficult in any country to say we've manufactured the vaccine, but we'll let the others use it first. It'll take a very brave politician to do that. But of course, what that will naturally lead is to this worries in the future, which will lead to not just sort of biosecurity nationalism, but also economic nationalism. So the other thing I think that'll inevitably happen is people will worry about their supply chains, particularly as it relates to medical care.
Sure.
So, where your masks come from, where your ventilators come from. So I think I won't go beyond these domains to the rest of business, but I think certainly when it comes to vaccines, and now in that domain, of course, Ashok, you said Serum was the largest vaccine manufacturer in India. I think Serum's the largest vaccine manufacturer in the world. So yeah, I think India is well positioned in that regard. So
sure.
Let me just add to that 2 points. One is it is highly improbable that any effective vaccine for the world will be made without India participating. So we can have some comfort in that. I think what we're seeing today is a knee-jerk reaction. Delhi just announced that it's only going to treat people from Delhi. I mean, what does that mean?
Crazy.
But
Crazy.
as we move along, as you know, this is a bad dream, we will go back to, because, you know, the supply chains in this world are too complex and too complicated to reposition. So I think what we're seeing is knee-jerk reaction right now.
Right.
So in fact,
Go
if I could just add, this Delhi phenomenon is just not in India. I'm in the state of Victoria here in Melbourne. I cannot travel to Adelaide in South Australia, even though our state has 2 cases a day, but they have 0. So, you know, it isn't as much, it's about much more about emotion than epidemiology at this stage.
Sure, absolutely. Now, I think perhaps we'll see this sort of, you know, some madness tempering down as we go forward. More questions. This is about the antibody tests. How effective are the antibody tests in gauging the number of immune people in a population? How do we ensure that we've seen there have been inaccuracies with few test kits, but how do we ensure that they throw up accurate results?
Should I take that?
Yeah, go ahead, Shahid.
Oh, sorry. So you have to understand that an antibody test is only accurate in a certain window period. If you test somebody very early, they would be negative. Similarly, if you test somebody with PCR very late, they would be negative. So the right time for testing is the most important. Antibody tests are only telling you the immune status of a person. It doesn't tell you whether the person is infectious, and it's not a confirmatory test. Beyond that, it has very good use to assess how far the virus has penetrated in a population.
Sure.
But I think if I could just add to that, what Shahid has said, people may think that just because they have antibodies as tested by a particular test, that they are now safe and protected. And I think that's a dangerous jump. Generally, antibodies protect, that's what they're there for. But until we understand enough which particular antibodies protect, what's the titer that's needed, how long do they stay, I think if someone can privately get a test and they turn out to be antibody positive and they think, well, I'm safe now, and that would be a wrong conclusion to draw.
That's right. Absolutely. Let's not get carried away with having a positive in antibody tests. I agree. This is a question which I want all the panelists to answer. If we have all are saying that a peak might come in July, if that happens, do we have to go into a lockdown mode again? I'll start with you, Shahid, then Ashok and Shitij. This is a very Indian context question.
Well, I think a national lockdown is not going to be really feasible. Yes, smaller lockdowns based on where the clusters are, is a real possibility. And I would again go back and say that place trust in communities to be able to do this and manage this. We are too big and too complex a country to do it, to have one solution fit all.
Ashok?
Yeah, I would just say that, there are diminishing returns from lockdowns. They're bound to be. And exactly what Shahid just said. At some stage, I think successful countries also have told communities, look, you know what's at risk here, and especially older populations, people with comorbidities, please take the normal precautions. We can't keep announcing lockdown after lockdown. We can't police everything in a country and hope for success.
What do you think, Shitij?
Well, the first thing is, I may not be aware of all the data, but I have not seen anything that gives me comfort that there'll be a peak in July. Because the peak would happen only under 2 circumstances. Either your lockdown or whatever protection measures are such that your reproduction rate has gone under 1. And I don't see why that would be the case now that we are loosening. It might be, So that's why. The other reason is that you're so close to herd immunity that you pretty much infected all the people you needed to infect. Now there just aren't that many more people to. So unless one of these two conditions is met, you don't actually see a peak. And I'm not convinced that either of those are close. But again, I do not know the Indian data. Now, having said that, I don't think it makes any sense talking about a national peak. In a country so varied and so diverse, even though on a graph, you can make a graph of India and yes, it'll go up and it'll go down. But I think from a it may be good in a newspaper, but from a public health point of view, you'll have to break it down to your manageable jurisdictions. And I could bet you that at a time when it seems like India is going up, there must be some jurisdictions which are actually going down. And therefore, and you know, vice versa. And therefore, the policies will have to be adjusted to your manageable jurisdictions. They may be states or districts or even places within districts. And that's exactly the lesson that you take away from Australia, that even though you publish a national curve, and often the newspapers report that, from those who are managing it, that's not the unit of analysis at which you want to look at it. The only place where it's important is national borders. So that's another story, you know, different from managing the pandemic.
Right. So how has been the experience for you? So going forward, what's the number that you guys look at?
Well, the numbers here have been good. As I said, we're down to single digits. But I'll tell you, we've been down to single digits for now nearly a month. It has been very hard to get those 5, 7, 9, 11, 3 to 5, 7, 9, 11 to go down to 0 and stay at 0. They go down to 0 for 3 days, then another state 3 pop up. So the point here is it'll require constant vigilance even once you're lucky enough to get the numbers down. The second is with respect to travel. At the moment, there is no non-essential travel into Australia. And if Australians leave and come back, they have to be in enforced and monitored quarantine for 2 weeks in a special designed hotel for this purpose. So if for some reason you just had to leave the country or you're an outsider coming into the country, there's a 14-day monitored quarantine. It's not that you'll do it yourself. You'll be actually monitored 24/7.
Right. And international flights, are you have you started that?
You know, there are few chartered special purpose flights, but no, there is no, but internal flights have started.
Okay. Okay. Same like I think.
Yeah.
Sure. Sure. We have time to take one question, and this is again a question for all the panelists. How do we see we can improve the international cooperation? You know, the pandemic gives us a chance to improve our international cooperation. How can we strengthen organization like WHO? We've seen some countries walking out, but how do we see that you know we bring all the parties involved together? Who wants to take the question first? Ashok, do you want to start?
No, I think I'll defer to two people who know more than me about this stuff. So I'll pass on this question. I don't have to add value on this.
Okay.
Look, the only thing I could do here is look to history. And I think the lessons from history, if you look at major international calamities, and the most recent one, perhaps you could say, is the First World War or the Second World War, it takes statesmen and stateswomen. So this is not in the hands of an individual making choice, and perhaps not even in the hands of local institutions. We're in the hands and the mercy of some, I don't know, 50 people around the world. If they have the right orientation and they choose to collaborate coming out of it, but not recede into nationalism, we might see a better world. On the other hand, I think if you look to the First and the Second World War, you see both examples. You see Marshall Plan for some of the world and two big blocs forming. And I just have no idea what we will see coming out of this.
Okay.
It could be both.
Okay. Shahid?
Well, it's very unfortunate what's happening to WHO and with WHO at this time. You know, you don't do this in the middle of a pandemic. It is time for international cooperation. It is not the time to worry about who gets elected in the United States in November. So, you know, it's very, very important that the world cooperates, because the pandemic, or rather the outbreak, I would say, is not over until the last case is dealt with. And with the travel and with the communications across the world today, even a case anywhere in the world is a threat to everyone in the world. And that's why it's very important for us to collaborate.
Right. We have time to take one more question, and this is for you, Ashok, specifically. Our viewer wants to know, the pandemic recovery requires collaborative action. How can the private sector contribute? There are a lot of stories on private hospitals not accepting COVID patients, and costs have become monumental for non-COVID related treatments. How do we ensure that the private sector is made accountable and also pulled in to do the job?
Yeah, about private hospitals turning down patients, I mean, I've heard contradictory reports about this, so I don't want to pin blame on those hospitals and go into that. The private sector can do a lot by channelizing CSR in the right directions. And I've been kind of harping on parts of the population which are getting ignored relatively more than others. So I think that's the most obvious thing. CSR is now going into some kind of a black hole. We don't know where exactly it's directed. I think that's an important thing that I would see.
Right. And how we've seen also great examples of private sector enterprises helping, especially when it comes to testing companies. We've seen most of them are from private enterprises. Is that on the innovation side? You think there needs to be more help taken from them?
I don't know about that, but I know of a sterling example of private sector example is what was referred to earlier is on PPE. We went with very little capability there when the textile manufacturers group came together, and we are now huge net surplus of PPE, and they've got the unit cost down. This is exactly the kind of thing that's required, which is a win-win both for the business and for the pandemic.
Right. Well, I think we are done with the time. And just to sum it up, the entire session, from the context of India, we still need to be cautious. The numbers are going up. There is really very little comfort that, that we have. But of course, there have been good success stories of the PPEs, the tests, the ramping of tests. And we need to stick from the gains that we have made, whatever it is. And I thank you so much, Shitij, for all the international perspective. I think more we learn from each other in terms of how to sort of mitigate the next wave that is going to come. It's going to be helpful. So thank you so much for all of us who's been joining through Facebook and to logged into the link. Thank you for the panelists too. So have a good day.
And thank you
very much. Thank you, Divya. Bye bye.